I see something that says live,
Good.
so we're both alive. I guess we're live. Good morning, Dr. Rosensweet.
Good morning, Carolyn.
Did you have a good 100 days off? It seems like a million years since I haven't seen you, like I always say.
I had a special time.
I know. So I'm very happy to hear that. God bless. That's wonderful. May I start out with my first question and then give it to you?
Please, yes.
Okie dokie. So this is a woman who says, I'm 60 years old. I had a total hysterectomy at 47. Kind of my story, but I didn't take pellets. And then she started taking hormones at 59. She says she's taking estrogen and progesterone cream, pregnenolone, DHEA. What she wants to talk about, and this is interesting to me, is that 10-year window that many of us hear about. Meaning, there's that 10-year window that we need to take hormones. And oftentimes we're told if we don't take those hormones within that 10-year window, it's a wrap.
Yes, this is an excellent question. Estrogen is so protective to the coronary arteries, in all arteries, but the coronaries are the ones that we have our greatest concern with for reasons.
Yes.
And the issue is protection against atherosclerosis, against hardening of the arteries. And the way we first learned this is most practicing physicians who deal with the general public are aware that you never hear of a young woman keeling over on a tennis court and having a heart attack and passing away.
Right.
Whereas you do hear that about young men, even in their 40s. The common thing is he was never sick a day in his life. He fell over on the tennis court and died of a heart attack. Because estrogen confers special protection to the arteries. And where the arteries are most vulnerable is from the coronary arteries, a lot because they receive the first pulsation of that heart, pushing that blood out. So the pressure is highest and the flow pressure is hardest against that coronary artery wall. So they're the most vulnerable. And so young women have much less risk for heart attack and stroke than young men do. But by the age of 60, the incidence is identical in men and women. In other words, somewhere along the line, women start getting vulnerable to coronary arteriosclerosis and arteriosclerosis everywhere. And it's because they lost their estrogen protection in menopause. You need estrogen to form an endometrial lining and menstruate. So even though your estrogen is declining from its maximum, estrogen's maximum at the age of 20 plus or minus, and then gradually over time it declines. Well, there's this moment in time when the estrogen really drops out because the ovaries stop and you stop having enough estrogen to produce a period. Estrogen continues to decline all the way into your 80s and 90s, but it's that cascade of the loss of estrogen that from that moment on, when a woman's lost her period, she starts developing a vulnerability to arteriosclerosis.
Okay.
10 years of vulnerability in some women who have other causes of arteriosclerosis, you need the other causes too. Those other causes are insulin resistance, elevated insulin. Insulin is one of the few things we know that actually injures arteries. So elevated insulin puts a woman at risk. In fact, we know this about diabetics who have elevated insulin for quite a while before they lose their insulin. They have special vulnerability to diabetes. Diabetics have special vulnerability to arteriosclerosis. In fact, it's their vascular problems that are some of the worst for diabetics. So insulin resistance. So there's other factors is really what I'm saying. The loss of estrogen makes the arteries vulnerable. There's other factors in the middle of life that come in. So we're talking diet, we're talking about the skill anyone has in dealing with stress, and elevated stress chemicals like cortisol increases insulin resistance, and the beat goes on, and the knee bone's connected to the thigh bone. So when the estrogen falls, there is a question about, is that woman who is going to go years without estrogen going to start developing arteriosclerosis? Not all women will. There's genetic propensity to arteriosclerosis, there's lipid issues, there's inflammatory issues. These are all in the realm of those who study functional medicine primarily. There's ways to prevent this. The knee bone's connected to the thigh bone. You can think of provocateurs to inflammation just that are occurring in the gut and from incomplete digestion. Yes, the knowledge base is big, but the great news is so much more is understood.
Yes.
Just the relationship of vitamin B12 and folate and to methylation and to the production of excessive homocysteine, which is injurious to arteries. There's a lot of things that play into arterial injury. So just because a woman is 60 years old and she hasn't had her estrogen for 10 years, she still has estrogen, but not much. That doesn't mean that she's going to get arteriosclerosis. There's so many moving parts. Now, one thing we know is that when the birth control pill came out, here a woman is taking a pill. She's taking estrogen plus a progestin, by mouth. These oral estrogens are known to rarely but definitely produce clotting in the veins. So a lot of young women, it's rare, but a lot of young women who took birth control pills developed clots in their veins, and some of those young women, those clots broke loose and went to the lungs, and some rarely, but some young women died. Oral estrogens promote the inflammatory response and the coagulation propensity. So one thing in menopause is, if you're going to be treated, this is a little sidebar, by estrogens, which every woman needs. There is no exception to that. Every woman. You don't take estrogens orally. They work beautifully when they're applied to the skin or mucous membranes. They work beautifully. You can get ideal levels just by rubbing, well, in our case, we love the organic oils way of dispensing these. Topical estrogens. Topical estrogens do not influence or increase coagulation. It does not increase inflammation. And there's more in-depth knowledge about that. But so a lot of the concern about this window of opportunity was a clot forming in an arteriosclerotic coronary artery. Because one day I was walking through a medical conference, and I was walking through the vendor section, which is always very interesting to me. I bumped into Gary Gordon, a medical doctor who founded chelation in the United States. He founded an organization called ACAM. He was a genius. And I said, I was so excited, I wanted to point out to Gary that I had found some indicators of a patient that was at risk for arteriosclerosis. And he said to me, and I'll never forget this, yeah, but it's about the clot, stupid. Spoken fellow, but it was such a friendly thing. We knew each other for years by then.
I don't know that I'd ever say that to you.
and he said, this is what people don't understand about heart attacks. Yes, there's arteriosclerosis of the coronary arteries that's possible, but it's not the arteriosclerosis that leads to a heart attack, that gives a person a heart attack. That's a very slow-moving process. The body knows even how to compensate by producing new channels, new arterial channels. And he said, but what the trouble is the surface of an arteriosclerotic artery looks like it's got barnacles on it.
Eek.
And that is a perfect site to provoke a clot. And that's why people get clots in coronary arteries. And when you couple that with an increased propensity to clot, that's true in America, like the clotting mechanism is a very complex, exquisite process, biochemical process. It's just astounding, really. And what it's so totally balanced because we don't want to clot too easily, or we'll just be clotting, just walking around the streets. But we don't want to clot not well enough because if we get hit by a javelin or whatever, or a spear,
As often happens.
we we surely want to be able to clot. So it's poised perfectly in the
You know,
middle.
it's really amazing. It really is. And we talk about this a lot and how the human anatomy just.
It's the coagulation cascade. And interestingly enough, in the United States of America, the population is skewed towards increased coagulability for very significant reasons, provoked by diet, by stress, and so there's an increased propensity to clot. So one of the reasons that half the people who die in the Western world or in the United States die from a heart attack or a stroke, and we really are dying from the arteriosclerosis and the clot that happens. And that's what Gary meant, that it's the clot that forms on the coronary artery. Oh my God, he's in the weeds again. I've dived into the details, but you asked the question, and we want to get the answer proper here. So
Well, it's not a stupid answer.
so it really comes down to in a 60-year-old woman who's been without her estrogen for 10 years, how many of the multitude of factors this you got going on that could lead to a heart attack. And just by not giving this woman oral estrogen, which provokes coagulation and provokes inflammation, because that's part of the deal is provoke inflammation. We don't want to be promoting inflammation. Just by not giving a woman oral estrogen, and by her getting her estrogens topically, this phenomena of increased coagulation and increased propensity to clot in a coronary artery is not there. Now, I have not answered this question yet.
No.
There's another factor that I've discussed with one of our authorities on the subject, and there's some stuff that we have not unraveled, and it doesn't make me feel like we're home free in a 60-year-old woman who hasn't seen estrogen for 10 years. I don't feel safe. So there have been 3 patients recently that in order to see if they were safe prior to treating them with hormones, we had them go to a cardiologist or their local doctor and have a test called a stress ultrasound. In women, that's better than another kind of, it's a cardiac stress ultrasound. And that's better than the injectable dye, which works a little better in men. And what we get there is a view to see, is the heart getting enough blood circulation? Because if the heart's getting enough blood circulation, it's very doubtful that there's a compromising arteriosclerosis. And in the 3 women that I tested, fortunately enough, they did not have a test that showed partial blood flow diminishing in the coronary arteries. We went that far to do an echo stress test, echocardiac stress test. It's really remarkable.
You know, when I first met you, this was something that you had suggested for me to ask my doctor, and I did. I went to the cardiologist, who I just loved, and thank you God I was okay, so I could proceed. But I had never heard that before. Nobody ever told me.
Yes. Now, here's another fact to put into the mix here. I'm not even finished with this simple question. I was discussing this window of opportunity meaning the best window to start treatment of a woman is early on in menopause. Now that is solid. I mean, the earlier we can treat a woman in the perimenopause, in the menopause, the better, the better, the better, for a lot of reasons. That does not mean we don't treat women who are elderly. I treated my 86-year-old mother-in-law and my 88-year-old mother, started them on hormones for the first time in their late 80s.
It's amazing.
Yes, and because the risks did not warrant the net needed benefit to these two women.
Right.
But you never say never, and it's always down to the exact same thing. You got to individualize the individual woman and really know the details and choose about, because there's always a path. So when this information got illuminated, I started discussing this new information about the window of opportunity and the propensity for clot in a woman who has seen estrogens for quite a while with one of my favorite colleagues, Jim Hernser, a compounding pharmacist just outside of Dallas. And he and I, he said, can you imagine all the women that we have treated with estrogen over the last 20 years, 25 years? And he said, in my case, I've treated women that are massively overweight, that have severe diabetes, and we weren't aware of this information about the window of opportunity. He said, and we're talking hundreds and hundreds and hundreds and hundreds of women that we didn't know, well, we didn't know, and we were just treating them. And I didn't have one instance of this heart attack from giving them full doses of estrogen. And have you, David? No, I hadn't either. So it's a very esoteric subject. And the simple thing is, it takes me down to what I've repeated on this in our interviews many times, that a woman going into perimenopause and menopause, it's good to learn stuff about it. Download our book. You'll learn a lot about it. But ultimately, your primary task is to link up with a healthcare professional that has specialized in menopause and knows all these details. And when they read your initial history, your medical history, they go, you're a person I want to get a coagulation study on. And LabCorp has purchased what Gary Gordon did is he marched me down to the blood clotting expert testing, laboratory testing, their booth. And they introduced me to the world's, in that time, they were the world's most expert on testing the coagulation profile. It's very complex and it's not inexpensive. And I've started testing with this lab called Chemex, which was eventually bought by a lab called Esoterics, which was eventually bought by LabCorp. So LabCorp offers this exquisite blood coagulation testing. So when in doubt, if we want to evaluate a woman's risk, I'm going to go so far as to get a stress echocardiogram and some coagulation studies. We want to know if a woman's at risk. We want to look at those coronary arteries as best as we can, and we want to look at her coagulation mechanism. So what needs to be done can be done. It's a matter of individualizing, and holy mackerel, who knows this stuff? Well, I tell you, you want a specialist who's devoted their career to specializing in treating women in menopause. Like, for example, I spend most of my time training and mentoring physicians, nurse practitioners, and prescribing compounding pharmacists and PAs to specialize in menopause. And in our basic training, 12 hours online, there's a whole section on coagulation, because you want to know all this stuff. And then taking it, so your job is to get out there and find an expert in treating women in menopause, that they're giving their career over to doing that.
Oh, Dr. Bergson.
Yeah, Dr. Bergson is there.
I guess Dr. Bergson is here. Good morning.
Devotee, so good to see you.
And Elizabeth too. We can't negate Elizabeth.
Yeah. And Devaki, Dr. Bergson and I are very, very old friends. My God, since the early 90s.
Well, she's famous out there in menopause land for sure.
For excellent reasons. She's extremely knowledgeable. Oh my God.
We can do a whole thing on her.
So I'm going back to this whole issue of the window of opportunity. You want someone who understands this, and then it's just a matter of routine. You go to someone who really knows what they're doing, and they take a medical history, and in that medical history, they get the information about what things are necessary to do to cover all bases, because we want to reduce risk as close to zero as we possibly can in treating with hormones, which are powerful biochemicals, so needed for your whole life, so beneficial, and you can get it right. So again, go shopping, find that expert. That's my answer.
Good morning, Joanne, and thank you, Dr. Rosensweet, for that answer, because many times as I'm up and doing my thing, I do get that question, and women are very, very frightened. They're like, oh my God, I haven't taken hormones in 14 years, and I can't because I'm beyond that 10-year window. Nobody talks about inflammation. Nobody talks about insulin resistance. And now that I'm in school, I understand some of that stuff. But, I think that your point is so well taken, and you say it every time, and I will repeat it again, that a woman absolutely will do herself a world of good by finding a physician who specializes in menopause, that knows exactly what he or she is talking about, and will take your case on with a passion. Because who doesn't want to feel better? I mean, I don't want to feel scared, And I got very, very lucky to be able to find these doctors, and I don't feel scared going into my third year, and I feel a lot better. So thank you very much for that answer. At the end of the day, you would say that, yes, it is okay for a woman to start hormones after that 10-year period.
I would say that first we evaluate her.
Okay, well, yeah.
Case by case. And again, when I was talking to my colleague, Jim Hernser, we thought about all the women we had treated over the years who probably were at risk, and we've never had an adverse event. So, medicine has many challenges, including really understanding the details and making wise decisions. We're all at risk. Holy mackerel.
Yeah.
We're at risk for thousands of diagnoses, including some really intense ones. And so the art is evaluate the risks and make the choices. It's always risk benefits. What I did, Carolyn, is I flashed Summer's question up on the screen, and she's saying, coronary arteries are good, had the CTA scan. I wonder which one you're talking about. If you're talking about the rapid CAT scan, which really ends in a calcium score, valuable if there's no calcium in there. Not enough information if that calcium score is a little higher than in the reference range. Not valuable, not enough. When calcium scores first came out, I was really excited about them because they were so non-invasive way to check out the coronaries. However, they have their limitations. So if your score is really, really low, that's really good. If there's no calcium in that coronary, how bad could it be? But if you're in a gray zone where there is some calcium in there, you got to take the next step to really know that your coronaries are okay. And neck carotids are good. That's great. The ultrasound. CRP is chronically elevated and homocysteine is elevated. Well, here I made a decision to not go into the whole world of functional medicine in this particular venue that we're doing, this Facebook Live. And because you even know this information, is your first name Summer? I'm not sure.
Her name is Elizabeth.
Elizabeth. Elizabeth, since you know this information, you have obviously have done some work on this, and you want to get at why in the heck is that CRP chronically elevated, and how elevated is it, and how high is that cardiac homocysteine? Just take the steps. We track it down until we see why they're elevated, and we address the factors, because these mysteries are solvable. And in the process of solving them, what happens? You just get healthier. So, yeah.
We're gonna call her Summer. I apologize, not Elizabeth.
Okay. Now, if I can learn how to take her off the screen there, maybe Andre, if he's still there, will give me a hint on how to do that. Otherwise, we're going to see Summer's question up there for quite a while.
May I ask you a question that I thought of? Because, there are so many hormones. I mean, cholesterol's a hormone, adrenaline's a hormone, insulin's a hormone. We have so many hormones. Usually we think about estrogen, progesterone, and testosterone as hormones. However, melatonin is also a hormone. Is it okay for a woman to just go out and buy some melatonin and take it to sleep?
Yeah.
Okay.
Yes, melatonin is just on its own one of the best brain antioxidants that there is.
Oh.
And I never test someone's melatonin, or I haven't for decades, because there's a really good test. If you take too much melatonin at night, you're going to wake up groggy, like you took an overdose of a sleeping pill. So you find your dose. One thing, melatonin behaves by the law of the therapeutic window, which means there's too much and too little. And if you take too much, you're not going to get a proper effect. If you take too little, you're not going to get a proper effect. You got to hit it right. So how I like to do melatonin is order from a good company. Oh, that's interesting. Your chiropractor, your nutritionist, your holistic and functional medicine physicians, your health coaches, they know the good companies. You want to buy it from them, or have them connect you up with a good company so that you get a good brand. And I like to start with a 0.5 milligram of melatonin one night, first night, and see if you feel it, and see if it helps your sleep. And if not, the next night, take 2 of those 0.5 milligram tablets. So you're taking a full milligram. Same thing. See if it helps. See if it affects your sleep. And let's say at 1.5 of those, 1.5 milligrams of melatonin, you got really good sleep. And then you still went up to 2 milligrams. See if you do better with that. And when you took 2 milligrams, oh my God, you still got terrific sleep. Now, there's so many moving parts to sleep. I'm not going to say that melatonin is going to do it for everybody. No way. But so you take, and then you go up to 2.5 milligrams of melatonin, and you wake up groggy. Oops, too much. Your dose is 2 milligrams. You found your dose by starting low, going for symptom alleviation, and even going further than symptom alleviation to symptoms of excess, and backing down from symptoms of excess. I titrate melatonin. That's how my favorite way to help a patient. Because if you pull 10 milligrams of melatonin and you're not getting effect, because there's all kinds of dosage strengths available, and there's advocates of really high dosage, well, you'll probably get the antioxidant protection of melatonin at these high doses, but you may not get the therapeutic help with sleep issues. So melatonin, like every subject, there's a lot of moving parts. But yes, now you made a statement, cholesterol is a hormone. Nope, that is not so. Cholesterol.
Sorry.
Cholesterol is a chemical, a biochemical, that is the raw material for steroid hormone production, and you can convert cholesterol through exquisite biochemical mechanisms inside your body into hormones. Like the first active conversion that really has pharmacological activity is pregnenolone.
Right.
So it's but cholesterol itself is not a hormone, and I would not.
I apologize.
And it's fine. And but it gives us an opportunity to elaborate on this. So as a strategy, because cholesterol is converted to pregnenolone is converted to many of the steroid hormones, it's not a great strategy to eat a lot of cholesterol to boost your hormone levels. I wouldn't.
Well, no, I wasn't going there.
Nor is it a good strategy to take pregnenolone and trust that it's going to find its way into the proper amount of estrogen, the proper amount of progesterone, the proper amount of corticosteroids, the proper amount of the androgens, testosterone and DHEA. No, nor is it a good idea to take DHEA and hope that it converts, which it does, into the estrogens and the androgens. No, you want to get it right. You want to take and really knowledgeable healthcare providers, those who are specializing in it. They're not going to give you the precursors just for the opportunity to give you the precursors, because those are easy and they're supplements and they don't have to have a license to prescribe them. They're going to give you the actual hormones, so they're going to give you biased. They're going to give you testosterone. They're going to give you DHEA, and they're going to give you progesterone. This is what you want. So I'm wandered a little bit there.
No, and that's okay. Your wandering is very intelligent wandering, and it's fine. A quick question came up that if someone sleeps normally and doesn't have a problem, is melatonin something good to take just for the antioxidant? I'm adding that in, the antioxidant effects for the brain.
Well, a case can be made for that, and here's what this comes down to: is practical. The practical, because if you don't need it for sleep, and you might need it for sleep, and you might need several other things for sleep. I put progesterone and estrogen at the top of that list as far as things to take for sleep in a menopausal woman, a perimenopausal woman. It brings us into the whole subject of nutritional supplements, common capsules and pills and powders. And there's a practical issue, because you can make a case for taking hundreds of supplements every day. And what I learned as someone who I always loved supplements, and what I learned is I had to be careful with the number of supplements that I prescribed to a patient, because I could overwhelm them, and I could get them to where it was just too much to take. It was too expensive, and they wound up not taking them,
right?
Because the whole taking process was too darn complex. So it's an art for any healthcare provider who's suggesting supplements to get the right amount to swallow, the right amount of times per day to take them, which could be once for many people, especially people who are new to supplements. So why didn't I answer that story of melatonin? Well, one could make a case that melatonin has value just for its antioxidant, brain antioxidants. So it would be on the list, but you look at the whole list and you choose the highest priorities. Maybe melatonin would slip in there because there wasn't 20 others that would also, you could make a strong case for. But that's how it really goes. You have to take into account everything when you're throwing supplements at somebody. But melatonin is a high quality, high value supplement, so it would certainly be on everyone's list, whether or not they need it for sleep or not. Yes.
We have talked about this, and we have often talked about women who have asked, is it okay to just take supplements because we are frightened of taking hormones?
Well, they're not going to work for menopause. Forget about it.
Thank you.
You're not going to need you're not going to get what you need. And we don't want it. This is an excellent question, Carolyn.
We're winging it here.
Why women wanted to address menopause with supplements was because of the massive incorrect information that exploded onto the American and world public in 2002 with the Women's Health Initiative study, which said incorrectly, wasn't even in their study, it was incorrect. They eventually retracted it, but nobody heard about the retraction. Everybody heard about the risk, which was false. Even in this published study, it was false. That women were at risk for breast cancer, heart attack, and stroke if they were treated with hormones. So
Yeah.
that properly, the misinformation, the wrong information, the opposite information than what's true, scared millions and millions and millions of women and the healthcare providers. And so alternative solutions to menopause, which is so clearly caused by a loss of these wonderful ovarian hormones, so it scared everybody. So they tried to find solutions through natural substances. Fair enough. I've been a holistic doctor for 52 years. Think about that for a moment.
I don't believe that for a second.
Yes, I was there wasn't a name for it when I got interested in nutrition and supplementation. I love them, but these hormones are so crucial. Why are women, just to cut down to the basics, why are there so many nursing homes and assisted living facilities? Why are there so many women in them? And so much, the reason is loss of hormones. Dr. Bergson and I had this discussion about what would Medicare look like and what would the nursing home and assisted living situation look like if women were treated with hormones. It could be massive lack of need for nursing homes and assisted living facilities. Because why do women go into nursing homes and assisted living facilities? They lose their muscles and they can no longer stand and walk with stability, and they progress to canes, then walkers, then wheelchairs, and that transition is enough for the family not to be able to take care of them. And you add to that the loss of the muscle that holds up the bladder and the vaginal atrophy from the loss of estrogens, and you got a perfect recipe for urinary incontinence and adult diapers known as Depends. This is another thing that gets women into assisted living facilities and nursing homes. And the third major thing that gets women in there is lack of cognitive ability, lack of ability to think. And even towards the dementia spectrum and even into dementia, there's a certain number of women who have dementia or really compromised cognitive function that is occurring simply from the loss of estrogens. So there you go. My God.
Well, those
do this with nutritional supplements, and there's going to be a certain number of women that, it's even known that 25% of women who go into menopause don't have symptoms. And then there's a certain percentage of women that they have the initial year or 2 or 3 of hot flashes and symptoms, and then they stop having them and say, oh, I made it through menopause. Wrong. Those of you who don't have symptoms and those of you who have made it through menopause, you're the ones that I am most concerned about, because you don't have any motivation.
Absolutely.
Who we see in our programs are women that are highly motivated. These symptoms are really life-stopping, and so let's not try. I love nutritional supplements. I take a handful every day, but I'm not trying to alleviate andropause with nutritional supplements. I tell you.
Right.
I'm using hormones.
Right. And how nice would it be, I mean, for those assisted livings to be empty, you know? Oftentimes, one of the first things that I will hear is, and I've done this, I left my remote in the refrigerator and I had the banana on the bed. I mean, you know, cognition is a really big deal for us, and it gets really scary when we forget. And lots of moving parts, I guess, to that too. But in the realm of menopause and what we've spoken of so often, I do believe, as you said, that estrogen can be very helpful for this. Am I correct?
Yes, it's crucial. And so many women who are in assisted living facilities with compromised cognition / dementia, had they been treated with estrogen, they wouldn't have gotten there.
Right.
I want to address a question here by Lisa.
Okay.
How long should it take? Let me see if I can make this switch the question. Yeah, look at that.
I don't know. You've got magic hands there because I
Yeah.
can't.
How long should it take for HRT to help with urinary symptoms? Well, there's causes of urinary symptoms, but the most common one in perimenopausal and menopausal women has relationship to two major functions. Number one, without estrogen, you get vaginal atrophy. This healthy vaginal tissue that's thick and moist changes to very thin and very fragile. And because the bladder empties into the end of the vagina through a tube called the urethral meatus, and the urethral meatus ends in the vagina, that vaginal atrophy affects that urethral meatus. It gets thin too, and it irritates that urethral meatus, and it makes women have to pee more frequently. And then you want to couple that with this whole other thing called, there's a muscle, it's a big muscle that's at the bottom of the pelvis that holds everything up there. You can contact that muscle. You can say hello to it. Let's all do it. Let's all close our eyes and squeeze your anus and let go. And squeeze your anus and let go. And squeeze your anus and let go. You are, and open your eyes, you are squeezing the levator ani. And you are strengthening the levator ani. And Dr. Kegel suggested that women do that several times a day. And I certainly think that's a fantastic idea, because when you lose that levator ani from loss of androgens, loss of female testosterone, remember, testosterone is not a male hormone. It is a human hormone. And when women lose their testosterone, they lose their muscles. Take a look at the thighs of elderly women. They're thin. Take a look at the muscle, the triceps muscle. Many women develop flab here that used to have muscles there. You need testosterone. You need your androgens to keep your muscles, or you're going to develop something called sarcopenia, muscle loss. And if you lose that levator ani, when you couple that with vaginal atrophy, you start getting incontinent. You can't hold back your urine because that same muscle also participates in the urinary sphincter. And so this is how adult women get into adult diapers called Depends. And those two things, loss of lower extremity stability from loss of muscles and bladder issues galore from vaginal atrophy, irritation of the urethral meatus, and the loss of the ability for the levator ani to hold everything where it belongs. It's got to hold up that uterus, it's got to hold up the bowel, and it's got to hold up the bladder. And when it doesn't do that anymore, that's how you get incontinent. So how long should you take HRT to help urinary symptoms? Forever.
I was just going to say forever.
When you go into perimenopause, every day that you're on Earth, or whenever you pick up on this, for every day that you're on Earth, and you'll celebrate it. And you don't just take it for the urinary symptoms, you take it for the vast multitude of how beneficial and important these hormones are for multiple organs like your muscles, your bones, your brain, your arteries, your skin, your hair. Oh, there's a few things, your sleep, your mood. These hormones are some of the most powerful chemicals that are circulating in our body. And when we lose them, we lose a lot. So
Life,
forever. Keep going here.
absolutely life changing.
I see
Yeah.
questions. I see questions.
And I see that you can, I'm going to leave it on you because this is your
Okay.
interview
How
today.
much do you have one, Carolyn?
Hmm?
Here's a question from Lily. Many women get diagnosed late in life with ADHD. How would bioidentical progesterone affect women with ADHD and low
Interesting.
progesterone who is not in menopause? Well, you're talking about something that develops some kind of cognition. I mean, I'm assuming that you're referring to adult onset ADHD. What does that stand for again?
Attention deficit
Yeah,
disorder?
attention deficit disorder. I wouldn't call, and we're just splitting hairs here, the kind of cognitive issues that women can develop in the perimenopause and menopause. I wouldn't go so far as to diagnose as ADHD, and it is a cognitive challenge, but we tend to think of ADHD as more of something that develops younger in life. And it matters because with the diagnosis of ADHD, you can be getting into other kinds of approaches to addressing it, like stimulants. And I wouldn't approach a woman who's having cognitive challenges. Yes, your attention isn't as acute as it used to be. And there's so many reasons for that. But I would go first to the hormones. Here's what we teach physicians, nurse practitioners, prescribing compounding pharmacists, and PAs. That when a woman shows up in the menopause and perimenopause with this brand new set of symptoms, and the list can be very long, treat the menopause first before going on some extensive medical workup trail and
Yes,
see
I love
what
that.
symptoms are left. And you want to treat the symptoms with great expertise, and you ultimately want to be testing with 24-hour urine hormone testing, not the urinary 5-point where you collect 5 different urinations on filter paper. No, too many technical issues with that, with the 24-hour urine hormone test. So you want to treat a woman beginning with alleviating her symptoms, and then finally testing her with a 24-hour urine hormone test to learn whether or not she's in the zone on all these hormones, the estrogens, the progesterone, the testosterone, and the DHEA. And then see how much, quote, ADHD is left. Yeah, low progesterone is not the only moving part when it relates to cognitive function. Yes, it's important. Yes, it does relate to the function of the brain, but I wouldn't list that as the first one. So just get the same task is there for everything. If these symptoms are brand new, get thee to a menopause specialist and get those hormones right, and not as from an amateur or not from someone who's not specializing in this. You wouldn't go to a general surgeon to get a knee replacement. You'd want someone who had an extra 3 years of residency and training and mentoring and has done 100 knees. That's who you want to go to. So anyway, specialization.
Absolutely specialization. I'm going to see if I can try and throw this in really quickly and if you'll accept the question. And anyway, I'll just start out. 24-hour urine is not available for me to get where I live. Is there any other test that you would recommend for us who cannot get the 24-hour urine yet being the operative?
Well, The interesting thing is, I don't know where you live. It's liable to be the moon. I'm just kidding. No, you're on Earth. Because as far as I know, there is no place on Earth where the 24-hour urine is not available. For example, the lab that we love and use all the time ships all over Canada, all over Europe. New York State is a bit of an issue. It's got a technicality associated with it, but it can be done. And other than that, everywhere in the United States and Canada, Europe, there isn't a place that I know of that you can't get the 24-hour urine. Whether you can get someone who's willing to interpret it,
Right, exactly.
familiar with it.
That's the important part.
Yeah, and I suggest that people check into becoming a member of the menopause method, because we are in so many different places and we plan to be everywhere. And when a woman does become a member, we go looking for somebody to enter our training program.
Yes. Yes.
We've got a few more minutes, and I'm looking at a lot of questions here on the right.
Oh, Dr. Rosensweet, thank you for taking over my own interview. I really appreciate it.
Well, you interrupt me just like you did. If you have a question, then it's
I have no problem doing that, but you're so fascinating that it's hard to do.
And you know so many of these women, so
you know I do, and thank you, God, I do. But you know what? They're getting to know you, and that's even more incredible, I think, because it's enabling us to really help, and that's what I'm all about, is helping, as you know.
You are.
I am. I can't help it.
Girl.
I cannot help it, Dr. David Rosenthal.
Here's a question I'd like to read from LaShawn Hill.
Okay.
And I just had my first abnormal cycle, which confirms my entry into perimenopause. I'm just afraid of being placed on birth control, as I believe this is how my sister developed cancer.
Yeah.
Well, a couple parts to that question. Women, and I've said this many times, women are at their peak ovarian hormone output at the age of 20 plus or minus. And from that point on, their hormone levels decline. And then they reach a point where these hormone levels have declined so much that it starts getting tricky cycles. That if a woman who used to be regular back in the day, I got this reverse thing with it. Back in the day, the woman used to have normal hormonal output and regular cycles. And yes, regular cycles are the sign of normal hormonal output. Any woman who's cycling religiously at 28 days plus or minus, for example, she's got a normal ovarian hormone output for the most part. But then as you get into your 30s and stuff, the progesterone can decline. Even though you're still ovulating, you need progesterone. You need to ovulate to produce progesterone. So these hormones are starting to decline and even give issues, sometimes as early as the early 30s. And then when you get that first abnormal cycle, a cycle that is irregular, you're so right, LaShawn, it's probable that your ovaries are not doing what they used to do when you were young, which is regular. And it's a perfect time to learn stuff. And so one of the first thing I recommend is download our book. Carolyn has made it available for no charge on ins and outs of menopause. So you can just go right to the Facebook page and download it and learn about it, because you're at the stage where it's good for you to learn a lot and to do the right thing. And it's a perfect time to start taking progesterone, because you can be sure when you had that abnormal cycle, you are plenty low in progesterone. You're already lower in estrogen than you've ever been in your adult life, but progesterone is not there, and to supplement that is great. Now the second thing, this is the big question. The birth control pill contains two hormones. Estrogen, not bioidentical exactly to the estrogen that's in your body, not molecularly identical. It's ethinylestradiol. That's a little bit of a different altered form of estrogen. And the second thing is it has this progestin molecule. And I'm going to suggest that this is not how your sister developed breast cancer. So over my shoulder, there is a book called Estrogen Matters. And I don't know, Carolyn, if you can type that name. I'm going to say it a couple more times. Estrogen Matters. Estrogen Matters. It's by Avram Blooming and Carol Tavris. Dr. Blooming is an oncologist. Dr. Blooming's wife had breast cancer and his daughter had breast cancer. And he is an absolute expert on the relationship of hormones to breast cancer. And the relationship is, oh my, now hear this. Women who take hormones are at less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones. Oh my God, that's absolutely contrary to what the vast majority of the public believes. And it's based on this that I'm going to suggest that this is probably not how your sister developed breast cancer. Now, I want to zero in a little deeper on this whole issue of breast cancer. To develop cancer, I like to think of things like this. And I've said this to patients very often, that let's pretend that we had a video of your whole life from the time you were conceived till now. And we, night and day. And we had a magic editing button. Then when we put that video on a computer, we press the button and all the good stuff got eliminated. All the happiness, the joy, the love, the good food that you ate, the exercise that you did, everything that relates to good health, that got all removed from the video. What would be left behind would be the multitude of issues of diet, exercise, supplementation, stress, and how you responded to it. It's not the stress, it's how you respond to it. Toxicity, all the multitude of exposures you had and adverse events you had. This is how people get ill. And then there's the mysterious. Oh my God, these life-threatening illnesses, all diagnoses. There's things that we can't understand that I believe very strongly relate to the heart and the soul and the destiny and some of the deepest issues we came to earth to identify and heal. We could call them spiritual issues. We could call them emotional issues. So this is how I'm going to suggest your sister developed breast cancer. Now, did estrogen play a role? There are some women that are extremely estrogen rich. No problem. You tend to have large breasts and you tend to be shorter of stature, although there are many exceptions to this because estrogen facilitates the closure of the long bones. So women who are very estrogen rich, very curvy, sometimes short of stature, sometimes large breasts from stimulation of breast glandular tissue, those are estrogen rich women. But this estrogen rich can go too far. It can be excessive. And estrogen is a stress hormone. It's recruited during the biological stress response when you are, the fight or flight response. And you can not only be estrogen rich, you can have many, many times of excessive estrogen output because you were trying to recruit your estrogen, which functions to support the stress response. Go figure. The fight or flight response, so does testosterone. And so from excessive estrogen output, you can get something called increased breast density because estrogen causes stimulation of breast glandular tissue. It actually causes mitosis. It happens once a month, actually. And you can have an excessive amount of that. So I'm diving into this very crucial question LaShawn is asking. And to address you directly, LaShawn, is what's this breast cancer about? And if we were to study very closely, very accurately, as we do in the menopause method, how your sister developed breast cancer, And I've done this with many patients because I'm treating women who've had prior breast cancer, that the breast cancer was properly treated. Well, women who've had the breast cancer properly treated, if they're treated with hormones, they're at less risk for recurrence than women who go untreated. So this is there's a lot to this. Must treat the breast cancer properly. So yes, you are giving a young woman who's at the peak of her estrogen and progesterone output additional estrogen plus a very questionable molecule known as progestins. They're not progesterone. These are a biochemical alteration. They are not identical to the progesterone that's in a woman's body. Well, here's how a woman's body responds to extra estrogen when she's young. It tries to protect her, and it uses a natural mechanism called sex hormone binding globulin, and it increases that sex hormone binding globulin to bind up more of the estrogen, which is why a certain percentage of women who are on birth control pills lose their libido, because it also binds up their testosterone. You know, I'm not trying to drench you and overwhelm you with information. And if anything you should take from this, it's the more information that is known, the better programs can be designed.
Absolutely.
I've told the story several times that I was very interested in cars, and I rebuilt an automobile engine, a Corvair van automobile engine, at the age of 28. And my God, it was so exciting to take it all apart, right down to everything, and then put it back together. And that car ran 7,000 miles, in which point it froze. That engine froze, and it became a playground fixture on a private preschool in New Mexico, in Santa Fe. And then I had a Volkswagen van, and it needed an engine rebuild. And this time I took it to a mechanic who specialized in rebuilding Volkswagen engines. And because I was so interested in cars, he let me watch him do the whole process. It took him a day.
One day.
I was fascinated. And he did 1,000 steps that I had left out from my wonderful instruction manual on how to rebuild an engine. Because he's done this, he's specialized in this. He had done his 10,000 hours, and I was just staggered with how much I didn't know. And so I'm not trying to deluge this, and because this, I'm taking you back to your primary job when you go into perimenopause and menopause. Find an expert, go shopping until you find someone who specializes in menopause, and we do, and you can contact us, and we can set you up with physicians and nurse practitioners that they're taking this on as a specialty. And again, I spend 80% of my professional time training and mentoring physicians and nurse practitioners how to specialize in this, because all these moving parts matter.
They do matter. And I have to, again, put this big old plug out there for Happy Healthy Hormones. That book is amazing. And I read it a good couple of years ago. I've continued to read it. As I've said, mine is underlined and highlighted. I downloaded it. It's in a binder. And it's great. It is really great. So everything that you just said, and there was a comment, put up that Dr. R is getting very tech savvy. Well, you're always tech savvy. You just
and there's another comment that I want to address. And someone
okay.
is replying to LaShawn Hill with information I do not agree with.
Okay.
And it says, well, no, it's not information. This is just a comment and a preference. I vote no to birth control pills. And I vote no to birth control pills. But the ability to have effective contraception really matters on this planet Earth. And you don't want to wipe out a tool that is so helpful to some young women as they're growing wise enough and mature enough to be an actual place where it's appropriate to become pregnant and have a child, and have found themselves in an appropriate relationship. This is a work in progress. And so I worked for Planned Parenthood, and I have some awareness about the general population, and you don't want the general. And I know you're not saying this, commenter. You just voted no personally to it. And the challenge is, if birth control really matters, and it matters to millions and millions and millions of young women, and you could give a much better birth control contraceptive method, and they come down to diaphragm plus condom. And now I'd like you to picture yourself in the field and trying to talk young men into using condoms, which offer a lot of birth control, but they're not perfect. There's definitely a pregnancy rate there. Or to have a young woman have a diaphragm and insist that her partner have a condom, that's really good protection, especially when you add the spermicide. Diaphragm, oh yeah, my favorite. But in combination with the spermicide you put in the diaphragm, oops, spermicide, whoa, oh, well, yeah. But contraception, it's always a risk-benefit analysis in medicine. And then diaphragm and condom, woo, that's a great combination. But there are so many young women and young men who are not going to do this. And, having a child prematurely can be much more consequential to their whole life. So I don't rule out birth control pills at all. And I'm not going to say that that's how your sister developed breast cancer, but I was going down the trail of increased breast density. So this is another subject, and excessive estrogen can cause increased breast density, and that's a risk factor. And so can underwire bra and compression bra wearing, and other things can. Exposure to environmental toxins can, which Dr. Berkson is an absolute expert on, and the details of how it affects. And Dr. Phyllis Brunson is an absolute expert on these progestins. So yes, I agree. There's so many healthier choices for birth control. But I'm not going to say that this is how your sister developed breast cancer. And the final thing I'd like to say, LaShawn, I mean, these questions are so profound. There's so much to them. That's the good news. There's a lot of information to bring to bear here. I am going to say to you, because you're concerned and there is cancer in your family, doesn't mean you're going to get it, is for you to also read the book Estrogen Matters. And you can get it on an audio book. And because you're getting into perimenopause, and it's a perfect time for you and all women to learn about menopause, because it will take you out into the world of practitioners, and it'll help you select the one that is right for you, because you're going to know what to ask them, and you're going to know how to select them, and you have to go shopping. They're not as common as they will be in 10 years from now, 20 years from now. The experts will be there. We're going to train a heck of a lot of them and make them available to you. And in this age of telemedicine, the whole thing can be done on Zoom, just like the Zoom that you're using to communicate. So we have reached the end of the time that I have for today.
We have. Let me just say this though quickly. I'll do a little name dropping. When I met with Dr. Blooming for lunch that fateful day, wonderful day, he wrote in my book. He said, the more we learn, the less we fear. And then I added to that then the more empowered we do become to be able to do that doctor shopping, know what we're looking for. And sometimes we get really lucky in that our doctors will allow themselves to be taught by us, which is really amazing and really fun when that happens too. So
I'm going to sign off, and hello to all of you. I see some familiar names here.
Me too.
Thank you once again, and we will do Facebook Live again this Thursday morning. And
we will.
We're heading into Christmas. Oh my God, very special time of the year. So much is available to us in Christmas. And I wish you all the very best and a very Merry Christmas. And I'll see some of you on Thursday. And Carolyn, I'll see you on Thursday. And I'm going to sign us off.
To everybody, thank you for being up here. Thank you for bearing with Dr. Rosensweet. Thank you so much always for doing this. Big hugs to everybody.